All right, we're going to finish up today before your exam next week on these next three chapters. Okay, chapter 8 is going to be on discussion of respiratory failure, which is something that you need to be able to identify and manage rapidly. Okay, when you talk about respiratory failure, you have to talk about two ways of looking at it. One is ventilatory failure, and the other one is oxygenation failure. And they're actually treated differently. Okay? Some people associate ventilatory failure immediately as being the same thing as oxygenating failure, and it's completely different. Okay? So we don't call ventilators anymore respirators. If you'd worked 40 years ago in the area of critical care, the machines would be called respirators. We've moved away from that. We call them now ventilators to sort of differentiate the two forms of respiratory failure. Okay, one is you require a mechanical device to assist your breathing, and the other one can be actually treated with oxygen therapy and other modalities that don't necessarily mean that you have to be intubated. Okay, so respiratory failure has two arms. The first one is oxygenation failure, okay, which is when you actually draw blood gas and see that the arterial blood, the PaO2 is actually too low for the situation you want it to be. And that's what we consider oxygenation failure. That's denoted usually as a PaO2 less than 60 millimeters of mercury. Now, always take in consideration that you need to be able to derive it from the alveolar gas equation, your AA gradient. Okay, if you have a PaO2 of 100, but you're on 100% oxygen, that's still a form of respiratory failure. In this case, an oxygenation failure. Okay, because that person should have a PaO2 in the 600 region, not in the 100 region. Okay, so that person's still having oxygenation failure, and you need to figure out what's causing it. Okay. On the other hand, if you have that person begins to have the inability to properly ventilate, they will start to have respiratory retention of CO2 in their bloodstream. Okay, so that indicates to you that the mechanics of the lung, and the diaphragm and the muscles, or the central drive is no longer functioning properly enough to stimulate the brain to then cause an activation and movement of minute ventilation to be able to remove the CO2. Now, what you can have at first is oxygenation failure, which then depletes enough of the ATP that then the muscles begin to fail, which is then called diaphragmatic failure. So your first step is oxygenation failure, then going into ventilatory failure. So you can see it as a continuum as well. Sometimes you can just have independently ventilatory failure with no oxygenation failure. You can have somebody who's on high FiO2s, and if you check their blood gas, their PaO2 is adequate, but their CO2 is in the 80s, 90s. And that is a form of ventilatory failure that's unique just by itself. This can happen with high doses of narcotics. If you give enough narcotics to somebody, you'll see their breathing rate drop way down, and then you'll develop what's called ventilatory failure. Okay? Most forms of ventilatory failures, if you can't reverse them quickly, will need some form of support, which means either an airway clearance or being able to intubate that individual to support their breathing. So the patterns that you see on the blood gases are kind of important. Okay? They can actually tell you if you have pure hypoventilation. Okay? If the person is, let's say, on room air gas, so this is all the requirement that you're on room air gas. And that's the trick when you look at this slide. You have to assume that these people are on room air gas. So if you don't have them on room air gas, then this sort of diagram sort of goes out the window. Okay? But if you draw blood gas on somebody who initially comes into the emergency room and has been basically on room air, and it's purely hypoventilation, let's say they do get narcotics, but they're not getting supplemental oxygen, okay? Then what's called pure hypoventilation occurs, which is the CO2 will rise rapidly, okay, as well as the PaO2 will fall. Okay? Most forms, there's different forms of oxygenation failures, but some of them are treated very easily with oxygen therapy. So pure hypoventilation, okay, that you can see, if you give them oxygen, the PaO2 will actually stay on the normal side or actually elevate. Okay? If you look at other forms of failure, which is like see a severe form of VQ inequality, okay, which is in B, you tend to see a little bit of a rise in CO2, but not as much as you may think, considering the situation you're in, because most of the time the central nervous system becomes stimulated enough to be able to increase its minute ventilation even though the oxygenation begins to fail. On the other hand, if you see severe interstitial disease, that usually doesn't affect so much the ventilatory mechanics, but affects the ability to uptake oxygen. With C, you only get a drop in PaO2, but no real drop or an increase in CO2. And in D, which is in ARDS, again, it's a diffusion limitation. You see severe hypoxemia, but with the severe hypoxemia, the person begins to hyperventilate very aggressively. So in the initial form of ARDS presentation, you get a severe hypoxemia and hypocarbia. That won't last long, okay? That will last for maybe 4 to 6 hours, and then the person will start driving their CO2 levels up, and that's what we call impending respiratory arrest, and that's when you need to support those people and intubate them. So if you see somebody in full-blown ARDS and the first blood gas that you're actually hypercarbic, that person needs to be intubated pretty soon, okay, if not urgently. If you treat the person with ARDS with oxygen, yes, will they increase their PaO2? Yes, they will respond to it, but they tend to stay hypocarbic. The reason they're doing that is because the work of breathing is tremendously increased with ARDS. You get a very significant restrictive kind of disease pattern, and to actually manage this decrease in lung compliance, the person breathes fast, and then the tidal volumes don't really increase. So you're not going to really diminish that by giving them oxygen therapy. Okay? On the other hand, if you take somebody with COPD and you give them oxygen, you may get yourself in a worse situation because this is the person that will develop hypercarbia because their CO2 is no longer really a very good drive mechanism. So they're really using oxygen to drive them to breathe. So as soon as you give them supplemental oxygen, they'll stop breathing almost completely and they'll get hypercarbic very quickly. Okay? And people that have COPD, you think that you're doing them a good treatment, they actually appear to be falling asleep. So you think, they're comfortable. Yeah, they're not falling asleep because they're comfortable. They're falling asleep because they're becoming hypercarbic. And they're getting CO2 narcosis. So hypoxemia, we talked about this before. We talked about oxygenation failure in previous discussions, and we'll talk about it again later down the road as well. But there's basically 4 reasons why you develop hypoxemia, which is hypoventilation, diffusion impairment, and VQ inequality. Those 3 tend to respond to oxygen therapy well. The one that doesn't, which is shunt, is the one that's more difficult to treat. And depending on how severe the shunt is, oxygen almost doesn't really respond that much. So shunt is not going to be responsive to oxygen therapy. The way you detect hypoxemia, of course, is, and remember, hypoxia is different than hypoxemia. Okay, hypoxia means that you're not getting oxygen in you from the atmosphere. Hypoxemia means you're not getting oxygen from the alveoli into the bloodstream. So there's a lack of oxygen in the blood. Okay? As soon as you get hypoxemic, you will develop cyanosis, which means the hemoglobin will not have enough oxygen bound to it, so the person will turn blue. Specifically where you see it most often is in the lips and in the fingernails. The heart, for most adults, will induce a significant tachycardia. In a child, on the other hand, you'll get a bradycardia and you'll get a cardiac arrest on your hands if you see this getting happening. So to actually get a kid back from a severe hypoxemia is support them immediately, give them oxygen therapy and get their oxygen above, and then use their bradycardia resolve very quickly. So if you're intubating a child and you see bradycardia, it's not the stimulation of the larynx, it's the actual intubation process that's the person's actually becoming hypoxemic. And you need to either stop what you're doing and resume ventilating, or intubate very rapidly because they're going to desaturate on you very, very rapidly after that. The CNS effects of hypoxemia is a lot of times confusion, agitation, and you will get the person to fight you a little bit at times, but usually it's mostly confusion. It's not hyper-aggressive behavior, and I'll talk to you about what hyper-aggressive behavior is like with CO2. And then blood gas PO2s, of course, are really indicative of what's really going on. You have to have your, always before you determine if that's actually normal, is look at your blood gas and also make sure that you determine what the FiO2 of the individual is and be able to figure out using the alveolar gas equation what that person's AA gradient should be. Tissue hypoxia now is different definition than hypoxemia. Hypoxemia means that you have a low oxygen a low oxygen concentration in your bloodstream. That's a PaO2 value that's low. Okay? You can actually have somebody who is normal, okay, and still be tissue hypoxic, okay, which is that the actual blood, not the blood, but the actual cellular oxygen level is lower than it should be, okay, or it's basically oxygen that's not reaching cells. So it's really a factor of oxygen delivery. This has to do with perfusion. You can actually have somebody who is on high doses of Levophed, and if you check their blood gas value, their PaO2 is normal, but if you were to see what their pH would be, very severely acidotic. Okay? Acidosis is an indication to you of tissue hypoxia. It's the end byproduct of that. Okay? Because if you don't provide enough oxygen to tissue, it immediately goes anaerobic and starts forming lactic acidosis. Okay? So arterial PO2 is really of small importance in telling you of tissue hypoxia. The oxygen carrying capacity of the blood, of course, is the carrying capacity equation, which is something you should already have memorized in the back of your mind. If you haven't, continue to memorize it because it may be asked in the test. That's two components you're looking at. One's the actual hemoglobin carrying capacity, and the other one's the actual dissolved PaO2 capacity, which is pretty low. It's almost insignificant. In clinical, we actually eliminate this last portion of the equation, and we just use the 1.39 times the hemoglobin times the saturation. Of course, tissue hypoxia can also be due to oxygen affinity to hemoglobin. Sometimes the hemoglobin will have too much binding of oxygen and won't release it. Yes? Shift to the right would actually be what you want. Yes, right. So when you have somebody that's shifted to the left, okay, the oxygen affinity for the hemoglobin is too high, and this can occur in somebody that is, let's say, given in bicarb, and you've made them actually alkalotic. You can actually induce a tissue hypoxemia in that point, or a tissue hypoxia, because now you're not allowing the hemoglobin to release the oxygen into the tissue level. The actual hemoglobin in the blood gas will look well saturated, but the tissue itself is starving for oxygen because you made that person alkalotic. That's why I keep telling you guys, don't reverse acidosis completely. Leave them slightly acidotic. It actually is better for tissue oxygen delivery. Normalizing somebody's pH completely and actually making them alkalotic is actually dangerous, and you don't want to ever do that. My consideration normal is 7.30. That's where my target is when I'm taking care of somebody critically ill. My target's never to go back up to 7.40 because I know that I can get into more problems if I get above it. So my target's around 7.32. And I know that at that level, the proteins don't denature. So the actual receptors are going to be functional, and you're going to have epinephrine be working, and all the other drugs are going to work fine. It's not going to be a problem. But getting them up to 7.40, that's your target. You're going to overdo it one time or more than one time, and you're going to be up above it, and then you're going to get more tissue hypoxia taking place, which is what you really want to avoid. Okay? It's not what's going on in the blood that matters. It's what's happening at the cellular level. Okay? Your brain really depends on oxygen a lot, and if you starve it because you make it bind onto the trucks, you don't want to leave the trucks because you want the trucks full. It doesn't make sense to do that. Okay? Does anybody not understand that concept? Yep. As you get towards tissue, the hemoglobin changes its configuration. It basically converts itself into something that will unload the oxygen out of it. The way I think about it is to sort of explain it to my kids when they ask me about this kind of stuff when they're in school. I tell them, look, think about it as it's a transformer. Okay? Hemoglobin, when it wants to basically just do its carrying, it converts itself into a truck. Okay? And like Primus. I don't know if you're into Transformers or not, but the big truck. Okay? And then when he wants to do something, when he wants to deliver it, he converts himself into the robot, which then pushes the boxes out and feeds them to it. If you force him to stay inside the truck mode, then he can't deliver anything, which is what you're doing with this. And that's why you don't want to make somebody alkalotic, okay? Because you prevent that truck from converting itself into that robot that can actually then deliver the oxygen molecules. Okay? Yes? Yes. The acidosis is a normal byproduct of metabolism at the tissue level. Okay? So if you look at the pH of blood from the lung to pH of the tissue, it's actually a gradient. Okay? The tissue, the actual lung pH is around 7.40. That's what it wants to stay at. When it gets down to the tissue level, in other words, beyond your blood gas, when you're drawing a blood gas, what you're basically measuring is what's going on in the lung. That's what people have a really hard time understanding. Why is this value what we care about? The answer is you don't, in one way, but in another way, it tells you what's going on at the lung level, but it's not really telling you what's going on at the tissue level. Okay? What happens after that, when the blood leaves this radial artery to the capillaries in the hand, that's when the hemoglobin begins to conform and change. Okay? Because when you get down to this level, the hand, the capillaries, the pH drops. It goes from 7.40, it drops down to about 7.31, 7.28. That's what you should expect. Okay? And that changes the hemoglobin molecule enough that it now wants to unload the oxygen. So you're right. But now if you see that the body, if you're drawing the blood gas and you're seeing that the pH is already low, that's bad. Because now the truck, instead of being a truck, is already a robot up here in the lung. So it doesn't suck up the oxygen like it should. And then when it goes out to the tissue, it doesn't have enough oxygen boxes to drop off either. So you've got to be in a sort of position where you want the hemoglobin truck to be a truck. If you drive it really down to a low pH, the truck's already unfolded, not taking up a lot of oxygen, and then doesn't really have the ability to deliver a lot of oxygen either. Okay, so being severely acidotic is dangerous too. So you're sort of stuck between a rock and a hard place. You've got to keep very tight control of your pH. Okay, does that make more sense? Sometimes it's visual. If you think about it visually, it makes more sense. If you're into numbers, that's fine, but most of us are not that intuitive as to think in numbers. Okay? Anybody else had a question? Okay. All right, so cardiac output, of course, is critical for delivery, okay, which is cardiac output times the actual oxygen carrying capacity. And, of course, distribution of blood flow is critical, and your body has the ability to shunt to different organ systems depending on the need. Remember, systemic vascular resistance is high in some organs in certain situations, but at other times the blood flow diverts to those and actually decreases blood flow to the brain. Like if you were to eat a large breakfast, right, this morning, you would feel tired about an hour and a half after breakfast. Or if you just had a big lunch, you'll find out that you're going to start feeling sleepy. It's not that you're bored necessarily, but it just means that your physiology is shifting the blood flow to the GI tract, and that takes it away from the brain. Okay, it's that simple. So the systemic system is not available to give every single piece of tissue the same amount of blood flow. It tries to differentiate where it should go. Now, there is tissue variability to levels of hypoxia that it can actually tolerate. Of course, the brain and the heart are not going to be tolerant of tissue hypoxia. Okay? The brain will not live much more than 5 minutes without oxygen. Okay? You're looking at, once you start going into 10 minutes, the brain is pretty much gone, and it's not going to reverse. Well, we're finding out that we're inducing hypothermia that to try to protect the brain, and if we can shut down the brain's cellular activity at the time of injury, we know that there has more capacity to tolerate this. The other thing that's been interesting that's happening in the study of tissue hypoxia is that if we pre-expose certain organs to hypoxia, then we actually activate a system inside the body that will protect that organ. Okay? And it's pretty important to begin to understand that, because in about 10 years from now, you'll hear that we will do certain kinds of procedures or medications that we give into patients before surgery to basically prevent them from developing injury or ischemic injury. Okay, that's already coming down the pike. Okay? Because we're beginning to understand how cellular apoptosis, which is cellular death, is taking place. And there's actually mechanisms genetically in place that if you tolerate tissue hypoxia, that that tissue will become more resistant to it. Now, clinically, we knew this a long time ago. We knew this about 25 years ago. One of the things that was taught when I was a student was that if you had a young man had a heart attack, say in the age of 40, his chance of dying was almost 80 to 90%. And everybody's like, it doesn't make sense. You know, you have a 40-year-old person who's healthy before and all of a sudden has suffered a heart attack, boom, they're dead. But a guy that's been 60, 65 years old that's been having angina for long periods of time and sort of having like stuttering infarcts, they have a bigger infarct than the guy that's 40 years old, and then the guy just continues surviving and did fine. And it didn't make sense to us. So a lot of people started asking, what is it that's happening? And initially it was thought the answer was collateral blood flow to the heart is improved. And clinically you don't see that. You don't see a new coronary developing on these individuals. So that's not the case. What's happening is that at the cellular level, the tissue is actually changing internally its environment. The genetics get activated for the DNA to resequence certain proteins and enzymes to protect the tissue from hypoxia. And it makes it more resistant to injury. So areas that they would normally kill the individual now are more resistant to it, and the person just gets ischemic and not has an infarct. Pretty interesting stuff. Okay? And a lot of people are moving towards learning how to take care of this more. Now, just because the heart's still going in somebody who is arrested on you, it doesn't necessarily mean that the brain's going to survive. And a lot of you have worked on patients that have been hypoxic on arrival to the emergency room or the ICU, and then had a aggressive CPR done, and then they were brought back, and then they were brought to the ICU, where you find out that the person has suffered a hypoxic brain death. Okay, so the hypoxic brain death only lasts 10 minutes, versus before you start seeing really the cardiac effects of tachycardia and bradycardia is usually anywhere between 10 to 15 minutes. So if you see somebody asystolic, that usually means that even if you were to resuscitate that individual, if they've been sitting there for at least 15 minutes down, that their brain is not going to do very well. Okay? The new ways of actually managing these patients is they're actually bringing them in, that if they're witnessed, arrested in the field, and they're brought back, and they're done quickly, they don't necessarily do that. But if they're unwitnessed and they're still brought back, then they're put into a hypothermic state in the ICU now. One of the things that you want to do, besides temperature, that you can be protective, is that glucose is pretty important. Why? Because glucose is used exclusively by the brain as its main energy metabolism. Okay? The heart, on the other hand, doesn't use glucose mostly. Okay? And most people think that the heart does, but actually it doesn't. Okay? The heart uses fatty acids for its work. Okay? But the brain, on the other hand, uses a lot of glucose, and if you give the person too much glucose, the cells continue to accept it, and two things will happen. One is they will form more edema, because glucose is an osmotic gradient, so when sugar is put into the tissue, it'll suck in more water with it, which is not necessarily good. You will actually increase the brain edema. And the other thing that glucose, when it's put into the brain, it has no way of taking the glucose and converting it to fat. It takes glucose and immediately converts it into ATP. And that mechanism requires energy and production of CO2, which can be detrimental, or acidosis. Okay? So glucose is something that is, if you have very high levels of glucose, you have actually a detrimental effect on the brain. The good thing about human brains is that we're learning that there's plasticity already in them. Okay? If you look at an MRI of a child in comparison to an MRI of an adult, the ventricles in a child are very thin. And the reason that they're so thin is that the actual ventricles volumes, the actual CSF volume, is actually fairly small, because the brain neurons is actually very high in a child. Once the child develops into an adult, and you begin to continue to lose neurons as you continue to grow, and your ventricles actually get larger. People that drink excessive amounts of alcohol actually will get deterioration of the brain even more rapidly. And you actually see that the retral ventricles actually very much are enlarged, and you can actually see the brain is actually further and further away from the actual cranium, so they have a lot more CSF. Okay? So, but kids don't have that. So when you have an injury in a kid, from a brain injury from a bleed, it's immediate. You'll see the kid will go down pretty quick. Adults, depending on how severe their shrinkage is, may actually not have any symptoms and still have a significant bleed in their head. And other people that have actually normal brains that are tight, then you will see as soon as they get any kind of bleed, they will become symptomatic, very similar to children. Okay, so if you don't have enough oxygen, what the cells always do is they convert. They want to produce ATP. That's what your cells always are trying to do. So they're trying to find a way to do that. If you go without oxygen, then your cytochrome oxidase pathway shuts down. Okay, so and because it shuts down, then the Krebs cycle shuts down. So the TCA cycle shuts down. So all you're left with now is a bunch of pyruvate, which is the end byproduct of glucose. And pyruvate has really nowhere to go. It can't go into the Krebs cycle. So what it does is instead of letting pyruvate build up, which is toxic, which forms into what's called pyruvic acid, which then causes cellular death, the body immediately uses another mechanism which we call anaerobic metabolism. And it converts pyruvate to lactate, okay, which then lactate converts into lactic acid. Okay? And the cells tend to tolerate that better than tolerating pyruvic acid. Okay? So that's where its mechanism is, and then produces some degree of ATP, but it's really marginal. It's only going to give you a few minutes of survival. It's not going to give you a lot of time. Now, does this happen in all human beings? And to my surprise, I thought it was pretty much ubiquitous to all human beings, but they had found recently a very small, very, very, very small percentage of humans actually have another mechanism in our system that they can actually take anaerobic metabolism and hyperactivate it, and they can actually go for prolonged periods of time with low levels of oxygen. These kind of individuals are some of these super long distance runners. They actually found that a guy that they did a study on him about 2 years ago. This guy runs ultra marathons. They're 50 to 100 miles a day. I can't imagine being running 10 miles. Can you imagine running 100 miles? So, what they found with this guy was when they were drawing his blood gases, they saw his lactic acid began to increase, which is what the expected result should be. Okay? And then within increasing the stress, you should expect the lactic acid to keep building up. And in this guy, it actually reversed and went down. So he's got another mechanism that's able to take the lactic acid and break it down rapidly and not have any of the deleterious effects of lactic acidosis, which is a very intriguing genetic difference, to say the least. And that's what makes his ability to run 50, 100 miles like he does it every day. The guy was interesting. Like, he was a stockbroker. He got bored with it, and he was about 20, 30 pounds overweight and started running. And he was like outrunning people that had run marathons for 15 years, and he started, running them into the ground. He wouldn't outspeed them, but he could outdistance them without any problems. And then they're finding out that he has this genetic difference. So it's pretty interesting. Now, what happens with severity of hypoxemia is that central nervous system of the person has an inability to put two complex thoughts together. Okay, so if you make them do arithmetic or things like that, they can't. Okay, where all this stuff actually came about was from what kind of studies? Do you guys know? How do they all come up with all these interesting diagnoses of hypoxemia? Okay, one of the things that would happen in World War II is that pilots, especially bombardier pilots, were actually flying in bombers at over 20,000 feet or 15,000 feet or higher. So they had to learn what happens if their mask was taken off, if they didn't have any oxygen. In those days, the oxygen mask failed all the time. They would crystallize in their lines, and then the oxygen wouldn't be fed into them. So they actually would develop hypoxemia, and they would actually suffocate to death up there, and they're flying. You can imagine that wouldn't be good for the crew. So they began to teach the pilots how to identify hypoxia. Okay? They made them do card tricks, do cards, and then identify the cards, and they started realizing they couldn't identify the cards correctly. So they were figuring out that central nervous system functions are really impaired. Mathematics was impaired very rapidly too. So addition was impaired significantly. Okay? So a lot of this actually came out of space flight and regular flight studies on individuals. One of the things that they teach you as well is they look for tachycardia. That's a pretty much symptom of low levels of oxygen for adults. Okay? Eventually, the person will develop a mild form of hypertension and will develop heart failure simply because the heart has enough oxygen that it can uptake. The person will develop HPV, which means that they'll develop hypoxic pulmonary vasoconstriction, which then will lead to right-sided heart failure. The kidneys will, of course, have impaired renal function because they develop ATN pretty quickly. The other thing that will happen is if you go into the next form of respiratory failure, which is ventilatory failure, is due to these three causes, which is hypoventilation. Okay, so it's pretty simple. Okay, for respiratory failure with hypercapnia, you really only have three major identifiers. Okay, one is hypoventilation, which is the most common problem for us to deal with. Okay, in patients that come in with high doses of narcotic on board, getting excessive sedatives on board, patients who have suffered seizures, okay, and then can't ventilate properly, okay, people that have any kind of muscular failure, such as Guillain-Barré, polio, you name it. Anything that happened to the muscle where it begins to fail will lead to hypoventilation. If you suffer a chest wall trauma, so when we talk about this next semester in the coexisting component, we'll talk about trauma, about flail chest and things like that. That'll come into play. So that's one form. The other one's VQ inequality. VQ inequality occurs from where you have destruction of alveolar to perfusion, which is things like emphysema, will lead to bad COPD, or severe interstitial disease will also give you a very severe degree of VQ inequality. ARDS is a typical example of very high VQ inequality. And then you also can get hypercapnia with somebody who already has underlying COPD, and you give them oxygen, and you basically suppress the central nervous system from actually actively ventilating. Even though everything else is intact, the muscles are working still, but the brain drive shuts down. So those are your three major ones you got to look at. So how do you identify that? Okay, with COPD. Okay, the COPD person that has usually already slightly elevated levels of CO2, usually in the 55 to 60 range, and you look at their blood gas, you see that their bicarb levels actually is elevated. Instead of being at 24 to 28, it's up to like 33, 34. That would indicate to you this is the kind of person that's going to be at high risk for developing respiratory arrest from oxygen. Okay. The other ones that have COPD that have normal blood gases are usually not the ones that are going to be at risk for this disease process. So these are persons that already present with already hypercarbia from the beginning. Those are the ones you have to really watch for. Okay? So be careful when you give them oxygen. Their oxygen sensors are already low. Then the stimulation is mostly by hypoxic drive that stops, and this person will then hypoventilate, and then it will ensue into ventilatory failure very, very, very rapidly. Now, what does hypercarbia do to you? Hypercarbia won't necessarily kill you. It won't, okay? But it will not make you happy, okay? Hypercarbia will basically do two things. One is it increases blood flow to the brain and increases blood flow to the lungs, okay? The lungs will actually vasodilate on you in hypercarbic states, and so will the brain. So the way I teach students is think of the brain, the lung as the same kind of system. In the sense, if you see hypercarbia rising or CO2 rising, the brain's going to get more blood flow to try to flush it through, so is the lungs. It's just going to try to flush out the CO2 out of the lungs as well. Okay? The rest of the body, on the other hand, is going to vasoconstrict intensely. Okay? So the rest of the blood vessels in your body, systemically below the brain, is going to vasoconstrict like a rock. Okay? So you're going to get hypertensive to the point that you will get into renal failure if you're not careful. Okay? Most of the time you're going to renal failure from hypercarbia, but you will see that the person has very significant systemic hypertension. I've never seen anybody come into the door that's hypercarbic, that is hypotensive. If they are hypotensive and hypercarbic, they're usually in profound septic shock, and that's something else that's going on. They've lost their volume, intravascular volume. But most people that come in with simply isolated hypoventilation failure are hypertensive until you intubate them. Okay? When you intubate them, what you will foolishly do, and I've seen this done in units for many, many years, is that the person giving the assistance of ventilation will immediately bag at 100 breaths per minute for some reason. I have never understood why that happens, but if you watch them, everybody's going like this. How fast can you ventilate down the CO2? And then everybody looks at the blood pressure and goes like, why'd the blood pressure go from 200 down to 60? And they say, what's the first answer everybody says? It's the drugs, of course. No, it has nothing to do with the drugs. You can give the drugs, and you would see, if you drew a blood gas in an A line, you would see a 20% drop in blood pressure, and that would be it. It's not until you start hyperventilating and blowing off that CO2, that's when the blood pressure goes to tanks. Okay? Especially if somebody's had ventilatory failure for a while, because if you're hypertensive for, let's say, 2 or 3 hours, what happens to the actual volume inside your blood vessels? Right, it's getting squeezed into the interstitial space. So when you drop that hypercarbic response of that vasoconstriction down systemically, and you drop them back down to normal, it dilates, there is absolutely no volume left, and you crash. Okay? So one of the things you got to learn is when you intubate some of these individuals, don't go crazy. Just ventilate them normally. In 15 minutes, they will be back down to a normal CO2. It'll take 15 minutes, but guess what you're doing for the next 15 minutes? Hanging a liter of fluid and dumping it in them. Because you've got to get them preloaded. If you do that, you don't get any hypotension, and it's so nice. Blood pressure goes maybe down to 100, and you're sort of stable there, and everybody's fine. You're not having to give pressors and caught up. How many people have seen that happen? How many people have known why it happened? Okay, now you know why it happens. Okay, so now you should never happen to you again, or at least you should expect it if you see somebody doing that to prevent them from doing it. Tell them to stop ventilating or slow down. Okay? Now, one of the things that you will get from cerebral vasodilation is that the person has an increased risk of headaches. It does increase cerebral blood flow, which is bad. If you have any kind of intracranial mass, you can actually herniate the individual because you're increasing the ICP pressures in that situation. You will get papilledema, and you'll get restlessness, tremor, slurred speech, asterixis, which means that you put your hands out and the person's vibrating. They get fluctuations in mood. And at very high levels, they basically just fall asleep. Usually the level is 80. Okay? And then if you're weaning this person off and they start breathing at 60 CO2, and you're saying, this person's breathing just fine. They seem to be doing okay. They're going to tolerate this just fine. And then you decide to pull the tube out because their CO2 is 60, but you're going to pull the tube out. Okay? Well, all I can tell you is better have 4 really big people in the room with you. Because if CO2 is a 60, the person's going to come out like a boxing match. And you're going to end up losing it. Okay? Because they're going to come out swinging. So if you see somebody with a CO2 of 60 and they're not had that for a long period of time, in other words, they're not really Pickwinian or somebody that you expect to have a CO2 of 60, the best thing to do at that point is just get them back down, blow off the CO2, let the ventilation continue, okay, till the CO2 comes back down to more normal levels, and then you reemerge them. How do I know that? Well, because I've learned by practice. Okay? And I recommend not doing it that way. I got burned every time I've done it that way. And said, if I have somebody that's elevated CO2, then it's usually because they don't have adequate reversal possibly going on. It could be that we gave them too much narcotics. That's not good either. Okay? So at that point, I just basically just put them back to sleep for a little bit. If I'm just running them spontaneously, I just resume my nitrous oxide for a little bit longer until the CO2 comes back down. And then once it gets to a more normal level, then we'll re-emerge them, and it's a lot more stable. Peripheral vasoconstriction, like I told you, is hypertension. Acidosis of respiratory failure, it depends on onset. Acute changes lead basically to rapid changes in pH. Okay? Chronic, on the other hand, the bicarb levels raise because the kidneys are able to compensate and they offset the fall in pH. So a lot of these people that have bad COPD, you'll see that their CO2 levels will be in the 30s. That's a typical sign that if you were to draw blood gas, their PCO2s would be in the 60s. Okay? So one of the things that I always do when I check my chemistries is I look at the CO2 levels on the chemistries. The CO2 on the chemistry is really a form of bicarb, okay, so which is the fourth number you get. You get sodium, potassium, chloride, and then you have a CO2 number. The CO2 is not a blood gas CO2. It's a CO2 that's derived from the breakdown process of bicarb. Okay? So if you see that number, it should be around 24 to 28 under normal circumstances. If you see that number says 33, 34, that person has a chronic hypercarbic situation or acidotic situation where now they're producing a large level of bicarbonate. Okay? So what you should do if that person comes in pre-op and you see a CO2 in the 30s is get a blood gas on this individual. You need to know what their normal CO2 is. If you see that blood gas CO2 comes back as 70, I had one guy came back with his CO2 was 85. I'm going like, you're kidding me, right? And his PO2 was actually 68. Okay, that's where the guy lived. Okay, CO2 is of 80 with a PO2 of 68. Okay, that's really kind of like okay, and the guy's actually walking around and having normal activities. And his pH was 7.40. Okay, his CO2 was 44. So his bicarb production by his kidneys was off the scale. Okay, now any way you did this guy's anesthetic, you were doomed. Okay. If you did this with sedation of any kind, you were doomed. The good thing, it was just foot surgery. So what we did was we did a spinal on him with a low spinal, and the guy did fine. But didn't let the level go above a T4, T6. This guy had a low spinal, and he didn't get not 1 ounce of sedation. You give this guy a little bit of Versed, you'll just push him right off the edge. You give him oxygen underneath his nose, you'll push him off the edge. Okay? So this is the kind of typical Pickwinian hypercarbic patient that you give a little oxygen to, and he'll just look at you. And I've had situations like this. The person's just looking at you, and they won't breathe. You tell them, breathe, and they'll breathe. And then as soon as you stop telling them to breathe, they just look at you. Dude, breathe. Okay? And their CO2 is going right through the roof. Okay? So those are the kind of patients you don't give oxygen to, you don't sedate them, and you just give them a regional with little effect. If you have major surgery, forget about it. Those guys are going to stay intubated. And the chance of you getting them off the ventilator is pretty low. Okay, so it's a bad sign. Combination respiratory metabolic acidosis, of course, is a bad thing. You'll see an elevation in CO2 levels and increased levels of lactic acid in that situation. The diaphragm is pretty important for controlling the ventilation in these individuals and everybody basically. 99% or 90% of the workload is done by the diaphragm. So if you increase the workload too much, the diaphragm will fail. Okay? What makes the situation more likely is things like hypoxemia and hypercarbia. Okay? One of the things that we're learning about the diaphragm is not a stupid organ, it's not a stupid muscle. It's a muscle that is heavily sensitized, which means it's got a lot of sensors in it. Okay? Those sensors are critical in them because it tells the diaphragm how much tone it should maintain per segment of diaphragm. So when you look at the diaphragm, you'll see it like in this picture as one single muscle. We should actually think about it instead as components of muscles that are attached to this sort of tendinous component in the middle. Okay? So you have this tendinous area in the middle, okay, which is pretty much is like a parachute, the way I think about it. And the edges of it, which is what these are, we should think of them as individual muscle components. Why am I coming up with that? And the books don't really say it. Well, we're starting to find out that each one of these muscle groups has sensors in them that are proprioceptors. They actually tell the diaphragm where its position's at and how much tone it should maintain. If you put somebody to sleep as soon as you give anything, I don't care if you use etomidate, Diprovan, Pentothal, no muscle relaxant at all, you lose 20% of the function of the diaphragm immediately. That's devastating for a muscle to lose that much function. Okay? The reason that is, we think, is that we suppress the proprioception response coming back to the brain. So the brain no longer knows where it should maintain the diaphragm. So FRC falls by 20% as soon as you put somebody to sleep under anesthesia. And that's really detrimental. Okay? Now, the types of respiratory failure that you'll see is acute overwhelming lung disease, such as ARDS. So you can have restrictive disease or obstructive disease. Things that also cause respiratory failure, these are more ventilatory failure forms, or neuromuscular diseases. Acute on chronic lung changes, of course. Somebody who has COPD then develops pneumonia and adds one more thing to it that the lung cannot compensate. ARDS and infant respiratory distress syndrome are very similar in the sense that both of them have caused damage at the alveolar level, and now you're affecting the surfactant capability on both of those diseases. What you see with like things like this is pneumonia. This is a form of right upper pneumonia. This could be, of course, infectious from viral, parasitic to bacterial. You could also have vascular problems such as PEs, or exposure to inhaled toxins can also do this. And severe hypoxemia or hypoxia is pretty common in these individuals. Neuromuscular diseases are when you suppress the respiratory drive centers. So anything that affects the central nervous system, anything from encephalitis, meningitis, polio, Guillain-Barré, myasthenia gravis, AML, muscular dystrophy, all those that are basically components of the neuromuscular components can cause basically failure of the respiratory system, and you get hypercarbia and hypoxemia in that result. Okay? Hypoventilation with CO2 retention and moderate hypoxemia seen with all these disorders. Acute on chronic, of course, you look at the underlying disorders of each of the chronic lung diseases like COPD, asthma, cystic fibrosis, and other forms of restrictive disease. Usually then a mild infection will attack these individuals and it'll have catastrophic results. So you'll see this if you worked in the medical ICU units. These are the patients you would tend to see. In surgery, we don't necessarily see this unless we're having a problem at the end of the case where if somebody's aspirated on us or something like that. Most people that have chronic diseases, and we can get them through the surgical procedure as long as it's not abdominal or thoracic, they tend to do okay. You will see that the person will become profoundly hypoxemic, hypercarbic, and develop respiratory acidosis. End results of these things basically are like direct injuries to the lung, chest trauma. We'll talk about this in coexisting and talk about flail chest. We can also talk about aspiration, which is Mendelssohn syndrome, TB, oxygen toxicity. All these things can result in acute adult respiratory distress syndrome. And it had many different names in the old days. We've just come to the new word, which is ARDS, and who knows, it will change in a few years. What we see is that it's an inflammatory combined infectious response. Not only do you have to have always an infection going on, but it's just that you have the inflammatory mediators get activated to excessive amounts, and you start seeing transudation of fluid into the interstitial space. So it's actually very much like pulmonary edema initially. But what happens pretty quickly in this disease process is that neutrophils get hyperactivated. So the macrophages get into the interstitial tissue, and they start releasing high amounts of free radicals and start causing alveolar damage. And the lung then floods out, and the type 2 alveolar cells can't produce surfactant anymore. So these people basically begin to die from the lack of alveolar distension. Okay, so everything begins to collapse. What you see is basically hemorrhagic edema with the pacification of the chest x-ray. You see like this kind of pattern. It's basically diffuse. And where it's really noticeable is in the base of the lungs. And you have to ask yourself, why does it affect the base of the lungs? And the answer is that's where blood flow is at. And if blood flow is bringing an immune response with it, which is what it does, it brings the white cells with it, where's the damage going to be the most? And the answer is at the bottom of the lungs. That's why ARDS, when you actually can take the person and put them on a swivel table, okay, we should actually rotate them, you can actually change the edema in different portions of the lung, making you able to ventilate that person more effectively. I don't know if anybody of you did that, but I used to do that as part of ICU work. We used to put people on these neuro tables, and we'd actually then spin them, put them upside down for a few hours. They could ventilate them better, and then as soon as we started getting in trouble, we'd rotate them back. Yeah, so it's actually a disease that actually migrates depending on gravity. Okay. All the time when you have ARDSs, you have very low lung compliance, and the lungs become very, very stiff, and you require high peak inspiratory pressures to treat these individuals. Most of the damage that occurs and persists in these individuals is that you try to ventilate these people when you can't. There's no more lung volume left. Okay? So instead, you try to use a fixed ventilator, like a fixed volume ventilator, and you start causing secondary injury to these individuals because you're giving too much volume. And they get what's called volume trauma from the injury. Okay? So what you do in these individuals is you use pressure, so like PCV modes, and then you develop what's called permissive hypercapnia, which is the treatment is basically allowing the CO2 to elevate, and you just deal with the oxygen. Okay? And you don't worry about the CO2 going in the 70s, 80s, 90s. You don't care. Okay, you just leave them like that. You completely neuromuscularly relax them. And I've done this with people with severe ARDS, and sometimes I get them back, sometimes I don't. Okay, I used to do this quite a bit. I prefer not to get into ARDS. ARDS is I think most of the time it's a preventable disease process. If you screwed up, that's why I think about it when you see ARDS. When you see ARDS, you gave too much flood to somebody, too much fluids to somebody. You cause their immune system to become hyperactivated by repeatedly getting this person having the same infection over and over again. That will give you a hyperactivated immune response. You're giving him too much oxygen therapy, which is you're giving 100% FiO2 for too long a period of time. All these will cause these kind of damages. Unfortunately, the mortality rate, if you do get this, is almost 60 to 70%. Some places it's even higher than that. I can tell you if you're working in certain medical ICU units where they still use volume, you can almost have 100% mortality of those individuals. Okay? So it really does make a difference how you actually treat these individuals at that point. But 99% of this is prevention. Don't get yourself to this point. If you look at some ICUs, it's almost pathognomonic of the actual treatment plan. I can tell you, if you took a poll of the people in this room, how many people had seen the ARDS, I could tell you what kind of unit who was managing it. Okay, if you see people that love high volume settings, ARDS is very high in that group. Okay, if you see other people that are using more pressure modes and low volume settings, you will see ARDS at lower rates, especially if you're not using high FiO2s. So the places where you see high amounts of ARDS, high volume settings when you get into problems with the lung, and high oxygen settings without PEEP. Okay. And then you have inflammatory respiratory distress syndrome. It's also similar to ARDS in the sense that, but that's usually initiated by something else, which then attacks the type alveolar cells. In infant respiratory distress syndrome, you already have a lack of type 2 alveolar cells that are because the kid's premature. These are premature infant lung diseases as well. They lack surfactant production. That's why you check the amniotic fluid lecithin sphygmomyelin level. And treatment is to give, when a woman's pregnant, steroids as well as possibly giving the kid exogenous surfactant. You always know you're working with surfactant because as soon as you walk in the room with the kid, you begin to slide. Okay, the surfactant gets on the floor, and it's like being on ice skates. Okay, it's really pretty impressive. Have anybody worked with surfactant before? Nobody? Okay. Right. But it's pretty impressive when you do use it on the kids. It does work. Surfactant therapy on ARDS hasn't really worked because it's more difficult to get the surfactant in the human lung, the adult lung. And the other problem is that it's a secondary injury. It's not the primary injury problem, which is what this is. So giving surfactant to these kids actually will ameliorate a lot of the problems. What does happen is if you try to use volume modes on these kids, you'll pop their lungs because you develop volume trauma. So you get a lot of these kids will develop chest tubes and stuff like that. Versus if you use pressure modes and you limit the pressure and you don't try to give excessive amounts of pressure to try to increase the ventilation, then you tend to do okay with these. Okay, and the management of respiratory failure is always go through the ABCs. Airway first. Okay? Airway counts. If the person is not getting oxygen in them because they don't have an airway, clear the airway, secure the airway immediately. Okay, that's number one importance. Okay? Second is treat breathing. Make sure the person is breathing adequately. So you check your breath sounds. Make sure the person has CO2 coming back to the endotracheal tube. Treat any underlying infections. Cardiac insufficiency should be treated very aggressively. And if you see a oxygenation failure, increase your FiO2 first as your first line of treatment. The reason you do that is not because that's what you expected to keep it there. It's just that you do that initially until you figure out what the problem is. Okay? Always increase your FiO2 initially. Then drop it down as fast as you can. Get it back down to as below 50% as fast as you can. Anyways, increasing your mean airway pressure is a way of treating oxygenation failure. This does not mean arterial pressure, this is mean airway pressure. So all these forms of treating oxygenation failure are basically by increasing mean airway pressure. The reason that works is because it maintains the alveoli open. Okay, the longer you maintain the alveoli open, the more chance the oxygen is going to transfer across into the blood. Okay, so that's why mean airway pressure treatments are effective for oxygenation failure. Things that will do this will be PEEP, CPAP, which is continuous positive airway pressure. PEEP is done at the end of the ventilatory cycle. CPAP is during the continuous cycle. So usually that's somebody spontaneously breathing. You can increase your I time, and you can do an increase in volume, which is what most people think of right away. The downside to that is that if you overdistend lung areas that don't want to be overdistended, you get what's called volutrauma, okay? And that's what you need to avoid. Okay? Hypercapnia is basically a sign of mechanical failure, and that requires usually mechanical ventilation. These are the people that do need to be intubated and then put on a machine to help them breathe. Okay? Sometimes you can, if you start getting hypercapnia that's early, you can use an assisted mode and get them out of trouble. Okay? Things like BiPAP, PSV sometimes will work enough to get them out of trouble. Okay? If you give the diaphragm enough oxygen, it will recover pretty quickly. Okay? But if it's persistent, where the person now has developed very significant hypercarbia and they've been hypoxemic for too long a period of time, the diaphragm is basically depleted its ATP and it's not going to recover fast enough, and you need to support them at that point. Okay? Yes? For who? In the anesthesia world, or in the OR, the reason that we don't use PEEP is because we already have intrinsic PEEP on all our ventilators of +3. Okay, so all our ventilators have +3 of PEEP. Right. The ventilators that you use in the ICU don't have any PEEP at all. Okay, so you give them immediately +5. Okay, so we already know that we have an intrinsic PEEP of +3 in most of our machines, so we don't give it because we don't want to be above 5. Okay, so you could give 5 of PEEP on everybody in the OR and it would not make any difference at all. It would not hurt them at all. Okay, and it's not a bad idea either. Okay, but just most people don't want to give PEEP during surgery because of decreased venous return. But most people don't understand that you already have an intrinsic PEEP of +3 in all your machines. Okay, because otherwise the bellows wouldn't go back up. The bellows wouldn't go back up. Okay, the bellows that we have in our machines ascend. You have to ask yourself, how does that ascend? How does it come back up? And that means that the expiratory valve is closed until the actual ventilator resumes back its initial state. And at that point, then the pressure builds up to +3, and then the valve opens. And then the bellows stay right there, because it means it's continuous +3 of pressure. Okay? Does that make sense? Not really. All right. Here, when we talk about the anesthesia machine a little bit more later down the road, hopefully next semester, we'll actually show it to you in the sim lab how that works. Okay? Trying to get that up and going. Any other questions before I stop this lecture? You could be, but there's not much you can do about it. Not if you have them on the ventilator. Not if you have them on the ventilator. If you're letting them spontaneously breathe, yes, because there's no expiratory valve on the bag side of it, okay, unless you close down the pop-off. I personally like CPAP. I use it all the time. If you see me do anesthesia at the end of a case, I will put everybody on CPAP. Okay, which is I put continuous positive air pressure, which is not, you don't read that anywhere in the textbooks. What I actually do is I'll get my oxygen up to 10 liters per minute, which is what I want to do anyways, to get the gas not to be rebreathed. And then I close my pop-off down, okay, to receive enough resistance that the person now has continuous airway pressure around +10 in the whole circuit. And what that does is it generates +10 of pressure all the way down into the lungs. The reason I do that is because I keep the alveoli from collapsing. Yep. Yep, and it's also on my electronic gauge too. Okay, so I got them both. And I just leave it at 10. And I just watch it. And what will happen is the person won't desaturate. You'll see people tell you, oh, I don't like letting somebody spontaneously breathe because if I try to let them spontaneously breathe, they desaturate. And the answer is they will. Because as soon as you take the pressure off, and even if you have free oxygen flow, if you have no pressure in the circuit, the lungs will just empty out on you. Okay, because you don't have a glottis. You have an endotracheal tube that's preventing your glottis from closing. Under normal circumstances, when you're sleeping, when you stop in between your breaths, as you begin to exhale out, your larynx begins to close down, and it keeps the air inside your air alveoli. But now you've bypassed that with endotracheal tube. So now this gas just allows the gas to come out of the lungs. So within about 5 to 10 minutes of trying to let somebody spontaneously breathe, now the lungs are collapsed, and then you got the person's getting hypoxemic on you, and then you got, I don't like doing that. So I agree with that. So that's not a good idea. So instead what I do is I do two things. One is the CPAP, and it does two things. One is it keeps the alveoli open, and the other thing that I think is kind of cool about it is it distends the lungs. Okay, it brings the lungs up to a certain state. And once the lung hits a certain state, what does your body do? All of you have seen this, but you don't realize what you're looking at. When you worked in the ICU and you saw somebody getting a ventilated breath, when it was excessive, what did the person do? They tried to exhale. They began to buck on the ventilator. And everybody says, well, they're bucking on the ventilator. No. Their alveoli are distended enough at that point that the person is trying to actively exhale. The body, it activates the diaphragm to exhale at that point. It's already telling you, the sensors go onto the brain, I'm over-distended, breathe off this gas that's in my lungs. I don't want this much volume in my alveoli. The same thing you do with CPAP. As soon as you get that lung up, you'll see the person will breathe faster on you. Instead of just letting them collapse, if you let the lung collapse, then the person has no reason to breathe. Then you have to only wait for the CO2 to build up, okay, which is not what you want. Okay, so I do it for those two reasons. Hypoxia is prevented, and you're getting the reflex action of activation of breathing. Kind of a cool thing. Try it one day if you want to. You don't have to just go. Don't go above 10. Okay. I don't want to hear somebody saying to me, "Well, you guys are teaching them at 30 centimeters of water, keeping them." No. 10's the maximum level you should go. Okay. If you're doing what's called an inspiratory capacity breath, that's different. Sometimes I'll also teach you that you need to re-recruit the alveoli, and that's you do what's called an inspiratory capacity breath, which is you have to go to 40 centimeters of water pressure for 7 to 8 seconds. And you got to hold it for 7 to 8 seconds. You'll see some people that have never read this stuff will freak on you. They'll say, oh, you're going to kill the patient. I says, no, as long as you stay to 7 to 8 seconds. If you do the initial recommendation, which was done about 20 years ago, was 15 seconds. You will do harm to somebody at 15 seconds. You will preload reduce them so much that their blood pressure will crash. Okay, but at 7 seconds, not a problem. Okay, but leaving somebody on closed pop-off with 30 centimeters of pressure is not smart. That's a good way of crashing somebody too. Okay, 10, nothing's going to happen. Okay, yes. As soon as they start breathing, I take them off it. Yeah. It's just my form of prevention from atelectasis from occurring. And once they start breathing, you'll see the pressure dropping. Just open them up and let them breathe. Okay? Because the downside of CPAP is it's a restrictor, right? So what happens to the ability for the lung to exhale properly? It does. It diminishes. So CO2 is retained. So in that situation, I don't want the CO2 retained. I want the person to blow off that CO2 and the other gases. So once I get them initiated in breathing, then I can shut down the CPAP. Good question. Okay. Anything else? I wouldn't be so bold as saying that. I would say that it helps prevent problems. I've noticed that my patients don't have as much hypoxemia post-op if I do that, versus if I try to let them spontaneously breathe by letting their lung basically drop down, then I have to fight to recruit the lung again, which is a pain because then the person wants to buck and fight me. So by doing the CPAP method, I find that I don't have to do that, and the patients seem to do better. So. That's fine, but what you're going to suffer is a 20% reduction in FRC. If you allow somebody to spontaneously breathe through anesthesia, which is perfectly safe to do as long as they have good normal lungs, it should be no problem. Okay? But you are going to suffer a 20% reduction in FRC no matter what. Even if you give them CPAP therapy, you're still going to have a 20% reduction in FRC when you extubate them. Okay? Because it takes about 8 to 12 hours for the person to recover that after anesthesia. Okay? Because you're still giving them narcotics, you're still giving them all these other things, so it takes time for the body to recruit that back. Okay? Now, some people will actually tell you that the only way to doing it is by mechanically ventilating everybody. And again, people have different outlooks on it. I'm just trying to teach you one way of thinking about it. Some people will tell you, well, I only mechanically ventilate all my patients down to the point that they're bucking, and then I pull them off and then let them spontaneously breathe. That's okay to do, okay? Especially in somebody who is hypercarbic already. You don't want them to spontaneously breathe under general anesthesia gases because their CO2 is going to be up in the 80s. So it's appropriate to ventilate some of those people down. There's downsides to it because what's their endpoint? Bucking. Bucking is their endpoint. When the person begins to fight you against the ventilators when they switch them over to let them breathe. So that's the downside because if you have an intraocular injury or you have somebody with high intracranial pressures that you don't want that happen to, or you're worried about an inguinal hernia that you don't want blowing out, then doing it that method can burn you. Okay, versus the other method of letting somebody spontaneously breathe, and you titrate the narcotics at the end, and you control them, you can actually pull the tube out with very little bucking or any activity at all. Different ways of doing it. You should learn both. There's appropriateness to everything you do. Don't believe one person's dogma. It doesn't work for every patient. You've got to look at the whole picture.